This conference will now be recorded.
Hello everyone, welcome to class. So as the new guideline has come about the hyperemesis and gravidarum, so let's do the class about it. Apart from this, there would be guideline discussion and also some questions, okay? And as the guideline has come new, so now the question will also come in both part 2 and part 3 exam from this guideline. There are few changes are there from the previous one, so that you should know. So now they have changed the definition. So there is a difference in the definition. So nausea vomiting uh, is diagnosed when the onset is prior to 16 weeks of gestation and when other causes of nausea vomiting has already been ruled out. Now, hyperemesis gravidarum definition is changed. Previously, it was not like that. Now, this guideline, hyperemesis diagnosis is like when the symptom will start in early pregnancy, nausea, vomiting, and they are severe enough to cause inability to eat or drink normally and strongly limiting the daily activities of living, and signs of dehydrations are there to contribute to diagnosis. Okay, so previously there were three criterias were there, like less than 5% of weight reduction, electrolyte imbalance, and dehydration. So that then we used to say hyperemesis gravidarum in previous guideline, but now that has become one of the criteria for inpatient care, and this is a definition of hyperemesis gravidarum. So there is a change in the definition. So now it is like severe enough to cause inability to eat, drink, and limitation of activities with dehydration of signs that are contributory for the diagnosis. So there is a change in definition. Now, apart from this, we go like incidence. So nausea vomiting affect 90%. Previously, it was 80. So now it is 90% of the women, and it is the most common cause of hospital admission in the pregnant woman. And typical stay, the patient would stay in the hospital would be 3 and 4 days. So these numbers would be yes important for the part two people because direct question come from here. Apart from this, it usually start between fourth and seventh week of pregnancy, and the peak would be ninth. And usually, most of the cases it would get resolved by 20th weeks of pregnancy in 90% of the women. And hyperemesis gravidarum, it usually affected 0.3 to 3.6% of the pregnant women. So this number would be important for the SBAs or part 2 people. Now they have this time in the guideline has given like mechanism for nausea vomiting and hyperemesis. Like what they say here is it is related to the vomiting, hypersensitivity to vomiting hormone growth differentiation factor 15. So there is a GDF factor 15. So this GDF 15 responsible for causing loss of appetite, taste aversion, nausea, vomiting, and weight loss. And when the pregnancy is there, like then the pleasant HCG and GDF, both are made when the genes in the placenta get activated, and they would have a peak and in the first half of pregnancy. And because of this GDF variation expression is there in the family, because of that it would be genetic risk also, and because of this there would be recurrence in the future pregnancies also. So this GDF that is responsible for it, that has been added, this mechanism of nausea vomiting and hyperemesis, this is again updated in this guideline. So if the nausea vomiting is there, we have to have a score. So this we already knew, it was previously in the guideline also. Now it is puke 24 index. So if it is 6, then it would be mild. If it is moderate, then it will be 7 to 12. If it is severe, then it is 13 to 15. Okay. Now, what is the 24-hour scoring system? It detects like three questions are usually asked. In last 24 hours, have you felt nauseated or sick to your stomach? In last 24 hours, any vomiting or you thrown up, how many times in last 24 hours you have dry heaves hatching without like anything coming up. So these are the criteria, but no need to remember because it's not important. But you have to know what is the mild, moderate, and severe. Okay. Another index that they have added in this guideline, it was not there previously, is the help index. This help index is a hyperemesis level prediction score. This is the help index. And help index, again, there are so many things they are asking. According to that, they are dividing them in the mild, moderate, and severe. So so much nobody can understand, nobody can remember, and not no need also. Only values will be enough. So help, if it is mild, then it will be 19. 20 to 32 it is moderate class categorization, and severe will be 32 33 to 60. So now this guideline has got for the like assessment, there are two type of scoring. Basically more commonly used will be the puke score only. But now like this help scoring has already been added in this new guideline. Now this part is same and it has to be same. Nausea, vomiting, and hyperemesis are associated with the hyponatremia, hypokalemia, and low serum urea, raised hematocrit, urea, with a metabolic hypercholoremic alkalosis. But if it is too severe, then metabolic acidosis may also develop. This would be important to know for the part 2 people, because a lot of SBAs are coming from here. Okay, this is, there would be, there can't be change here. Now biochemical thyrotoxicosis, this we already know also, that two-thirds of the women with HG, that is hyperemesis gravidarum, may have abnormal thyroid stimulation test. It happens because there is a similarity between TSH structure and also beta HCG structure. So because the structural similarity is there, so there would be increase free thyroxine level or T4 level. But TSH, either it will be without a suppression of the TSH will not be there. So you will find that T4 is high, but TSH is normal, or there would be no problem with the TSH. This will be biochemical thyrotoxicosis only. And now if the patient comes to you and one having biochemical thyrotoxicosis, another patient really having a clinical thyrotoxicosis, so how would you recognize? So in biochemical thyrotoxicosis, usually thyroid antibodies are not there, and they are euthyroid, clinically no symptoms will be there. So this would be the differentiating point. Apart from this, for biochemical thyrotoxicosis, no treatment is required with any kind of antithyroid drug. So these two things are important to know. Okay. Now what would happen to liver function test? So liver function test will be abnormal in 40% of the women. And what could be the abnormality? The abnormality will be raised in transaminases, and both bilirubin amylase level may be mildly elevated. And as these like bilirubin amylase or other levels, they will come back to normal as when the hyperemesis resolves. Now this is again a new thing that is given in this guideline. And the ketonuria is not an indicator of dehydration, and it is should not be associated with severity of nausea, vomiting, and hyperemesis. So this previous guideline, they were doing ketone quantification. Okay. But in this guideline, they have removed it, and rather they have said that it is not the indicator of dehydration, not associated with this condition only. So this is again a change that they have done here, so that you should understand. Now whenever the patient comes to you, with the history with the hyperemesis, then you have to take some points in the history that is important. Now this would be important for both part 2 and part 3 people. So first of all, you will be doing the assessment right now, either with the PUQE score or score, and you would be asking about nausea, vomiting, hypersalivation, spitting, weight loss, inability to tolerate fluids and food, and ability to perform daily activities. You would also ask whether there had been any nutritional like status or rapid weight loss. Previous history of nausea, vomiting, or hyperemesis gravidarum is there. Comorbidities should also had to be asked, because whether they are on any other medication for like epilepsy, diabetes, HIV, psychiatric condition, hypoadrenalism. And because if the nausea vomiting is there and they have got these comorbid conditions, then uh, in that situation, medication intake would be also affected. It would also be important to ask about surgical history such as gastric bypass, bed or sleep, and history of so this would be the general history. Apart from this, it is the hyperemesis is there, but there could be other associated causes also. There could be so ask about the abdominal pain, urinary tract symptoms, or any drug history like recreational or prescription drug, or chronic H. pylori infection is there or not. So these are the points that you have to take in the history. If the patient reported to you with this hyperemesis and nausea, vomiting, okay, this check, this is important for part 3 viva, very important. Now once the patient is in front of you, after you have taken history, you need to do certain examination also. So what are the examination? Temperature for rule out infection, heart rate, because in dehydration tachycardia is there, blood pressure, yes, there could be hypotension, oxygen saturation, respiratory rate, there could be tachypnea in dehydration, abdominal examination, weight, signs of dehydration need to be seen. What are the signs of dehydration? Sunken eyes, dry lip or mouth, oliguria or anuria, tachycardia, or hypotension. And signs of malnutrition like rapid weight loss, muscle wasting measured by mid-arm circumference. Again, in previous guideline, they were speaking about weight loss only, more than 5% or equal to of the previous pregnancy weight. Now they are also saying to measure the muscle wasting by mid-arm circumference. Apart from this, what you have to see is the neurological signs, any confusion, nystagmus, ataxia, because there could be possibility of associated vernix encephalopathy. So these are examination to be done in the woman presenting with the hyperemesis gravidarum, and this table is important, for both part 2 and part 3 people. Now, once the patient is there, after examination, we need to proceed to investigation. So, what investigation has to be done? Now, urine analysis. So, if the nitrites are there, we can think of possibility of UTI. And presence and absence of ketonuria is not an indicator of dehydration. So, assessment of ketones has got no role in management of nausea, vomiting, of pregnancy and hyperemesis. Now they are saying this may be misleading also. Because of that, I have put that this line in a red in color, because previously they were doing, as I said, you already know, they were doing protein quantification for dehydration, and this guideline they don't want, they have removed it. Apart from this, they are saying that it would be misleading. So this part you guys have to understand, because you already know that the part of the guideline where the change is there, that would be the place where from where they would be asking the questions. Then if the urine dipstick is come positive, Then consideration of culture and sensitivity to rule out urinary tract infection. Urine electrolyte, like if a patient is on IV fluid replacement, so monitoring has to be done by electrolytes only. So to see whether hyponatremia, kalemia, or any kidney previous kidney disease is there, or if high creatinine and urea, possibility of even acute kidney injury is there due to dehydration. Now, apart from this, what we need to do is the full blood count. Why? That will give an idea about anemia, infection, and hematocrit, glucose level, to exclude diabetic ketoacidosis or to diagnose diabetes also. Now the scan can be done, and what could be the finding in the scan? It could be either viable singleton pregnancy, possibility of multiple pregnancy, and molar or trophoblastic disease also. So these are the few investigations that you have to do whenever you are doing your case based discussion in part 3 stations. All Whenever whatever the test you are doing, always you have to explain to the examiner the reason why you are doing it. Okay, so it would be very important, and this guideline explains it very nicely. Now, there would be certain patients, those who are refractory to treatment, not responding to the treatment, and they have a history of previous admissions. So, some more test investigations has to be done, not in routine but in refractory cases. This will be thyroid function test, liver function test. Why? To rule out any hepatitis, gallstone, and to rule out any associated pancreatitis. Apart from this, venous blood gases, to rule out any associated metabolic disturbances to monitor severity. So these were the investigations. You have to know very clearly what you are going to do in the routine cases and what you are going to do in the refractory cases. Now, investigations are also done. Then what will be the next step? Would be the treatment options. Usually, the patient having mild nausea and vomiting, they would be cured in the community with the antiemetics. Okay, so like if they require if they are not responding to oral, so consideration for even intramuscular or other routes can be done. So basically, other routes are the oral or intramuscular. They are given. They are considering giving in community, so that hospital admission can be avoided. Unnecessary hospital admission can be avoided. So what they say, that the woman is present, those women having nausea and vomiting, but other complication or dehydrations are not there, so they can be cared in the community with the antiemetic, reassurance, oral hydration, dietary advice. And what would be the dietary advice? Eat little and often, and to prevent empty stomach. So this will be the care in the community. In community, acute care at home or even the hospital at home services are there. What these kind of services? IV treatment can be given in the community, and these services can be utilized for IV rehydration even at the home also. Those who are unable to maintain hydration orally, and they don't have any complications and comorbidity. So the main aim would be to treat the patient uh, as possible as far as possible in the community only with the antiemetics, but and consideration for home care or acute care at home or hospital care for the IV rehydration, so that the hospitalization can be avoided. Okay, so this you should know. Now, ambulatory care. Wh- uh, when the ambulatory day care would be given, when the patient, whatever the treatment given in the community or primary care has failed, and the patient is unable to take oral antiemetics and oral fluids. So if the oral treatment is not possible, or the patient is not responding to the treatment, then patient has to given in ambulatory care. Okay, so now any one of you can answer this question. Which of the following is not indication for the inpatient treatment? Which of the following is not indication for inpatient treatment? Anyone want to answer?
Puke 7. Puke
Yes,
score 7.
7. Yes, actually the answer question is very very easy, and it is very clear also. So all other are the indication of inpatient treatment. So these are the indications for inpatient treatment, and this you should know because it can be asked in part 3 and also in part 2. So continued nausea and vomiting and inability to keep down with the oral antiemetics, continued vomiting with a clinical hydration, dehydration, and the weight loss greater than 5% despite oral antiemetics. Now, previously it was their criteria for hyperemesis. Now, this time they have removed that criteria as the definition has changed. Now, it is the one of the criteria for inpatient care. Any associated suspected or confirmed comorbidity such as UTI, because the patient is not able to take oral antibiotics. Any associated comorbidity, epilepsy, diabetes, HIV, psychiatric hypoarousalism, or psychiatric disease, where the symptoms and inability to take oral intake is not there. So, and if the treatment is not done, there would be another complications. So these are indications. Apart from this, recurrent or ongoing HG or NVP also will require ambulatory care, in particular if the electrolyte imbalance and the nutritional deficiencies are there. So these are the criteria where the patient be considered for inpatient care or the hospital care. Now, ideally, the patient is coming in the ideal emergency scan has to be done, because why? Want to rule out multiple pregnancy and trophoblastic disease. But if it is like if the medical reasons for urgent scan is not there, then it can be postponed to the next available appointment also. So ideally in care it should be done to confirm the viability and to confirm the diagnosis. So this otherwise it will be postponed. So this would be the inpatient care criterias. Okay, now uh, coming to antiemetics. So what they say that different type of drugs can be used, and in the women who are not responding to the single antiemetic. Now we already know that there are three line of medication. It was there in the previous guideline also, but this guideline, yeah, a little changes there. And you have to know this for part 3 and part 2 people, because the direct questions are asked from here. So now they have changed their first line. The first line is doxylamine and pyridoxine B6 2020 per orally night, and if it is required, then increase 10-10 in morning and also in the lunch time. So RCOG giving this combination now, but we have been using this from years as our first line. So now the RCOG also says this. So it is like doxylamine and pyridoxine. That is a vitamin B6. So you have to remember this. So double dose like 2020 at night, and if it is necessary, then morning and afternoon also 10-10 milligram can be given, and it is available with this name like Zenovia. This name, this tablet is available. Apart from this doxylamine, another could be cyclizine 50 milligram orally, IM or IV. Another will be uh, prochlorperazine and then it would be promethazine and chloropromazine. So it is very difficult to remember all these doses, but yes, at least one dose, at least remember one or two doses like doxylamine and paradoxine and cyclizine. If you could remember these two doses also, then it would be fine, because so much dose remember nobody can do it. Now, what they say, there is a safety data about antihistaminics, phenothiazines, and pyridoxine and doxylamine. So they are the first line of treatment. Delayed release combination for doxylamine and pyridoxine is the only licensed treatment for NVP in UK, and it should be used for my first line for mild and moderate like NVP requiring treatment. So this is, so delayed release doxylamine paradoxin is the for like only licensed medication for NVP in pregnancy in UK. So here this is the change, it was previously not there. Minimum at least one this dose and one cyclizine. If two you can remember, that it will be fine, because it is difficult, nobody can remember so many doses. Then second line, it was previously also same, but few things they have added. So metaclopromide, that is 5 to 10 milligram 8 hourly, but orally IV, IM and SC. Then domperidone and also the ondansetron. At least remember one dose, like because name of all, but dose of one, because it is very difficult to remember. Now, ondansetron, about ondansetron, what they have said, that it can be given 4 gram 8 hourly or 8 gram 12 hourly, and if it is IV, then 8 gram milligram is given over 15 minute, and 12 hourly 12 hour IV, 12 hourly it can be given. Patient who take ondansetron may require laxative, because constipation it can develop along with the ondansetron. And there is evidence to prove that ondansetron is safe, but there is small risk of orofacial clefting when ondansetron is used in the first trimester. Apart from this, metaclopramide is also safe, but as we already know, with the metaclopramide, there is a possibility of having extrapyramidal effects and also tardive dyskinesia. So, if IV metoclopramide is given, it can be given by the slowly bolus injection over 3-minute time to reduce EPS symptom and also tardive dyskinesia. So, metoclopramide short-term use, and maximum dose is like 30 milligram in 24 hours, and it should be zero point 0.5 milligram per kilogram of body weight in 24 hours, whichever is the lowest. And maximum duration metaclopramide can be given is the 5 days only. So these are some like salient features about these drugs that I found important, and you guys should know for the clinical knowledge also and for the purpose of this exam. So this part, these are the second line. Third line, it is same only, it was previous, there is no change here. So hydrocortisone 100 milligram, intravenously BD, till the clinical improvement occurs. After that, oral tablet prednisolone 40 to 50 milligram. This is gradually then tapered. We know that for the steroids we do tapering, and it is 5 milligram, 5 to 10 milligram per week, and very low maintenance dose has to be offered. Now, if the corticosteroids are women are taking corticosteroid, so their blood pressure to be monitored, and also their sugar has to be seen. Now, what the data is there, that trimester it is not associated with increase in the congenital malformation overall, specifically no increase in orofacial clefting, cardiac defects, or hypospadiasis. Okay, so this is all about the third line drug hydrocortisone. It is the almost same that is given in the previous guideline, and this is the summary of all antiemetics. So at uh, get remember by the name, first line, second line, and third line, and at least dose of one from each group you can remember. Whole table remembering is like quite difficult. Now, if the patient is not able to take orally, then then consideration for another routes can be done, like parenteral, transdermal, or rectal. They may be necessary, and sometimes these are more effective than the oral treatment. Now, when the patient has there could be some side effect can be there, or there could adverse effects can be there in nausea and vomiting. How to counteract with them? So usually there could be, if the patient is on IV fluid, what can happen is a electrolyte disbalance. So electrolyte checks can be done basic on the daily basis. Second, sometime they also have got gastroesophageal reflux disease, that is GORD, or esophagitis gastritis. So usually histamine type 2 receptor blocker or proton pump inhibitor like antacid also you have to consider giving. Apart from this, thiamine supplementation, either it could be oral 100 milligram 3 times a day, or IV vitamin B complex to be given to all women have admitted with nausea, vomiting, and hyperemesis with a reduced dietary intake. And it this has to be the thiamine deficiency has to be corrected before any kind of dextrose or parenteral nutrition is started. And why it is necessary, we already know that if the patient's thiamine supplementation is not completed, and if the patient is given dextrose, then it would lead to precipitation of vernix encephalopathy because of the thiamine deficiency. So this part is also important to know. So whenever the patient get admitted, first correction of thiamine supplementation is done. Apart from this, when the patient is admitted, we already know that there would be risk of VTE. So VT risk assessment is done, and accordingly, like heparin would be added, or like stocking. And this question can become in part two, for part two, that women with hyperemesis gravidarum has an increased risk of VTE with the odds ratio of 2.5. Okay, maybe they can ask this question. Apart from this, iron containing supplements has to be avoided because they will further cause precipitates the problem. If the patient has constipation because they are taking less flow food and medications, so laxatives can be offered. And what the what their studies have shown, if the treatment for protein pump inhibitors, they are given with antiemetic, like antiemetic and antacid together, then the patient would have improved quality of life scores, and they will have reduced puke. So these are the few things that you guys has to remember. Now another question. So if the patient has got hyperemesis gravidarum, and she has a history of gastric band bypass or sleeve surgery, so what do you think? Which vitamin deficiency would be common? Any rough guess? Anyone?
Vitamin B12.
K and B1.
Yes. So vitamin K and vitamin B1. So these deficiencies would be common. Okay. Vitamin B12 is not in the question only. So, hyperemesis gravidarum increases the risk in some conditions such as diabetes mellitus, or previous history of gastric band, gastric bypass, or sleeve surgery. So specialist advice required for that woman, because if the history of like bariatric surgery history is there, they may call malabsorption of oral medication, and also nutritional deficiency, thiamine and vitamin K. Apart from this, in the woman IV fluid we are offering, electrolyte imbalance could be there, hyponatremia and anemia. So electrolyte checks daily to be done. And if it is necessary, like patient is presenting with a severe gastric pain or hematemesis, even the esophago gastroduodenoscopy can be considered. Okay, so these are the few other treatment can be added, and the treatment could be effective if these associated conditions are there. Now, it is important to know about Wernicke's encephalopathy. And Wernicke's encephalopathy is caused by deficiency of thiamine or vitamin B1. What will be the presentation of the patient? Blurring vision, and the confusion, memory problems, drowsiness, and on examination there would be nystagmus, ophthalmoplegia, hyporeflexia, areflexia, and gait or finger or nose ataxia. And this is like presentation can be is all of is of slow onset. It is fatal medical emergency. And like it can be prevented if the electrolyte balance is like if the thiamine supplementation is given before dextrose or parenteral nutrition starts. So it can be prevented. And one study what they say, that the cognitive disorder occurred in 65 to 0.4% of pregnancies, and pregnancy loss occur in 50. So now you guys can understand that so much important condition, and the medical emergency it is. Otherwise there would be pregnancy loss in 50%. So that is a quite big number. So we take care of this thiamine supplementation beforehand. This would also be the reason that will tell you that why we are giving thiamine supplementation and why there is so much stress on it. Now if the patient we are doing treatment, and the what how should be the ongoing antenatal care. When the patient is fine, she's accepting oral nutrition or hydration, then we can discharge her. Apart from this, when the patient is getting discharged, we should give her complete idea how she can assess the care further. Uh, uh, if the nausea and vomiting are continued to late second and third trimester, then serial scan to monitor fetal growth to be done. So it is not like every patient who has hyperemesis should go for serial growth scan. It is only the patient who had continued symptoms of hyperemesis till second trimester, or even the late second trimester, or even third trimester. Those patient would be offered serial scan for the fetal growth. So this part would be important for part 2 people, because there could be SPA from this line. So, how many women will be readmitted after discharge from the hospital after hyperemesis treatment? Any guess? Not very important question, but any guess?
I'm on third.
Yes, one third. So, one third of the women will be readmitted within the same pregnancy. Because of that, patient is advised to continue their antiemetics, and they should be given a complete clear advice when they have to come back to the health facility again. Now, oral rehydration, how the rehydration would be done, so that we already know that it is a sodium normal saline 0.9% with added potassium chloride in each bag. So this is the appropriate most appropriate intravenous hydration with the daily monitoring of electrolyte. As we already know, dextrose infusion is not recommended. Apart from this, dextrose containing solution can prevent vernix encephalopathy, so they are avoided. And like parenteral thiamine to be added to prevent the vernix encephalopathy. And though the dextrose fluid can be considered in third trimester to prevent starvation ketosis. So in first trimester they are not offering that. Now what could be the now it is like patients usually affected by this condition would have both there should be a thorough assessment of physical and mental status, and if and like they can be referred for if necessary they can be referred for the psychological support. Apart from this, if the pre-existing mental condition is there, that is like worsened by the hyperemesis, so proactive use of antiemetic and appropriate referral to be considered. Now a patient to be given support group advice. On the other side, it is very poor mental health can persist in postpartum, and hyperemesis gravidarum is a risk factor for post traumatic stress disorder. So this part is also very important, that the mental health is so much affected, so that it could be one of the risk factor for postpartum traumatic stress disorders. So how many times hyperemesis is associated with low quality of life? Any rough guess? 3 to 6 times. So, effect on hyperemesis on daily functioning. Women with hyperemesis have got 3 to 6 times more likely low quality of life. So, it is a multidisciplinary approach that would be required. So, involvement of mental health team for emotional, sometimes psychological or psychiatric support, and the dietitian, because that would be give the clear advice about her diet plan, because oral supplement may be required as the food intake would be like inadequate in this woman. So it is mental health assessment, help and support for the psychological or psychiatric care, and also dietitian review. Now there could be some conditions where parenteral or enteral treatment to be considered. Okay, like patient they're unable to take anything orally, so what to be done? It is the enteral or parenteral treatment. In enteral treatment, it multidisciplinary approach is required for this, and the patient is referred to gastroenterology. So there could be enteral tube, like it will be or there could be parenteral treatment. Enteral tube, it could be nasogastric, nasoduodenal, and nasovaginal tubes, or even percutaneous endoscopic gastrotomy, gastrojejunostomy. Feeding can be considered, and this will again be a multidisciplinary approach. So, feeding is done by the peripherally inserted central catheter, and it is a little better tolerated, but it do carry very high risk of infection and also vascular complications. So, enteral feeding and parenteral feeding done only after multidisciplinary approach. Now, if the like nasovaginal feeding is done, so can be inserted endoscopically or under radiological guidance. And what they have seen, that if the treatment is started, then within 48 hours, people uh, no- shows improvement in the symptom of like vomiting and nausea and vomiting. And percutaneous jejunostomy tube, they are also placed in the anesthetic under general anesthesia in the second trimester. They are also percutaneous tubes. They are also known to be effective and well tolerated, and these tubes would be removed after birth. Early dislodgement will be less in case of percutaneous tube rather than nasogastric. You can understand if the if the tube is put through nose, more chances of dislodgement. So though it is a little part of it never asked in your questions, but a little knowledge is important whatever given in the guideline. Now it is not without complication. So they can enteral and parenteral nutrition can have serious complication, thrombosis, metabolic disturbances, and infection. And percutaneous treatment, infection complication could be like they have put a tube, so tube will dislodge. There could be obstruction of the tube, there could be migration, there could be fistula formation, there could be abscess formation, there could be occlusion and interstitial ischemia. Just knowing that much would be enough, because too much detail about this and the questions are not being asked from here. Now, what percentage of the women would want a termination of pregnancy in hyperemesis gravidarum? This question usually comes. Any rough guess?
10%, ma'am.
Yes, 10%.
5%.
10, 10, 10. It is 10%. Previous guideline also it was 10 only. So, like a decision of termination of pregnancy and hyperemesis. So, like treatment, if the treatment option with the antiemetics, corticosteroid, enteral tube feeding, parenteral feeding, correction of electrolyte imbalance, so everything should be considered before deciding for termination of pregnancy. It has to be multidisciplinary approach with the complete documentation, and women should be counseled before and after the decision, the whatever when the termination is done. So and as we already know, the 10% of the women with hyperemesis will go for termination also for this condition. Now, the things can be so worst for some of them. Long term effect usually what can happen in pregnancy, long term effect of hyperemesis gravidarum, there could be risk of postnatal depression, anxiety, and post traumatic stress disorder. Okay, apart from this there could be chances of recurrence in the future pregnancy. So this could be the long term effect and of nvp and hyperemesis gravidarum on the woman in the with the pregnancy. So what are the reported rate of recurrence varied in hyperemesis gravidarum? Any guess? How much is the recurrence? Yes, 15 to 81 is the recurrence. Now, what should be done in the future pregnancy? In the future pregnancy, advice to be given about the lifestyle modification and antiemetics. What they have given in the tables is about the preemptive like treatment. That means when the patient like gets pregnant, so they start antiemetic from the beginning, and usually doxylamine and pyridoxine 6 2020 dose is given as a preemptive diagnose treatment for this. Okay, now this is all given in the guideline, but they have given very nicely, they have summarized the information in the form of chart. This is a summary for gp, and for like not everything has already been, I have spoken already, no need to discuss about that. Now this is the very important that they have summarized. When the patient comes, how would be the initial assessment? So first of all, there will be diagnosis assessment and score documentation, QE score documentation, and the weight of the patient. Now if if the score is less than 12, then antiemetic in management can be done in the community, like antiemetics, oral rehydration, and support and reassurance, like dietary advices to take little and often to prevent empty stomach, a consideration for laxative if it is necessary, antacid if the patient develops GORD or gastroesophageal reflux disease, and mental health assessment. If it is necessary, then the referral to perinatal mental health team. So this is they have tabulated how the treatment or management is done in the community. Reassessment of the patient in 1 to 3 days. If the patient is improving, the same treatment would continue. If the patient is not improving, then second or third line of the antiemetic can also be added. So they say sometimes women may require three antiemetic and their effect will be added to each other. Now, if the puke score is more than 13, but the patient has no complication, consideration for ambulatory care. And if any red flag is there, then you have to consider referring the patient to inpatient care. What are the red flag? If any associated complication with any puke score, when the patient is unresponsive to outpatient treatment, unable to take any oral fluid, clinical dehydration, weight loss more than 5%, associated comorbidity such as UTI or diabetes, comorbidity, and unable to take medication such as epilepsy, HIV, and hypoadrenalism, psychiatric disorders, and concerns about the mental health. So these are the red flags that would require for inpatient treatment. So this is the initial assessment of the patient. Then manage then management in general practice. Can you see here general practice? They have given the various table: management in general practice, ambulatory care, inpatient care. So like they have this guideline. So these tables are there. So now when the patient comes in GP practice, what will be done? This history will be taken. The points I have already explained you. So this is the history that is taken: previous history of hyperemesis, hypersalivation, weight loss, poor intake, oral intake, effect on quality of life, effect on mental health, and examination: pulse, blood pressure, respiratory rate, temperature, physical examination, dehydration, malnutrition, signs are seen, neurological symptoms, and the abdominal examination. Then they will send investigation, that this will be urine dipstick and urea electrolytes, full blood count, and the blood glucose. So now they have taken history, they have examined, they have investigated. After that, we need to do the puke scoring. On the basis of puke scoring, then they will decide on what type of treatment is required. Less than 12, management in the community, like I already spoken. And if it is less than 13, and but there had been no complication, then ambulatory care. Any red flag, then inpatient care. Okay. Now these are the antiemetic therapy. We already know this is the titration of therapy, where more than one drug can be selected. Different classes of drug may have synergistic effect. So some of the women, they may require more than three antiemetics. Okay. Like consideration for the GORD patient, consideration for histamine type 2 receptor blocker or proton pump inhibitor, that is antacid, thiamine supplementation, like VT risk assessment, and the laxatives. And apart from this, this is the postpartum care. Postpartum care, it is one of the risk factor for post traumatic stress disorder. So if necessary, they should be referred appropriately. Future pregnancy, there is a risk of recurrence or lifestyle modification to be done. And also preemptive use of doxylamine pyridoxine can be considered in the future subsequent pregnancy. And the dose will be 20 per orally at night, with the confirmation of positive test. And the further titration is done as when it is required. So this is about the postpartum care. Now these are the support groups. So pregnancy sickness support, her foundation, UK teratology information service, best use of medicine in pregnancy. So these are the few things also they have very beautifully given. Now this is the management of nausea and vomiting. uh, and this is So this is in the general practice. This is the I have just previously I have already explained this, but this is the whole summary of the management in the general practice. Like this I have explained that this is the general practice: history, examination, investigation, diagnosis, documentation, and how is the management according to the puke system. What are the medications and what is the postpartum care. This is the complete same document in one picture. This is the management of nausea vomiting in general practice. Okay, now ambulatory care. Now so we know community care, we know general practice care, we know the ambulatory care. Ambulatory care where intravenous fluid will be given. So say this thing, when the patient is in the ambulatory care, so this part is same, like diagnosis confirmation, examination, investigation, puke scoring. After that, they, if it is puke is less than 12, they will discharge to community, and the community care would continue. And advice is given about hydration, antiemetics, dietary advice, and referral to perinatal health team if it is required. Now, if the patient has got score more than 13 and they have got no complication is not there, but they are unable to take any oral fluid, then what can be done? Ambulatory care. In ambulatory care, patient will have an IV access. Relevant blood tests are done. These are the blood tests you already know: urea electrolyte, full blood count, blood glucose, and this if it is in the refractory cases. Then IV fluid antiemetics can be given IM or IV, and fluid is given. Now this is the fluid: zero point 0.9 percent of normal saline with 20 millimole of potassium chloride over 1 to 2 hour. So this is the complete answer. This doses were not previous guideline. This dose was not there. And thiamine supplementation, either 50 milligram TDS per orally or Pabrinex, that is IV, a vial of each, and it is 1 plus 1 given via the IV. So this is the only difference in the management in ambulatory care, because patient will get IV rehydration. Rest all part is the same. Now this part I have already discussed. It is same in ambulatory care also. This is the complete summary of ambulatory care. Complete summary of ambulatory care. But basically you have to read this orange box only, that I have already done. Now, what is Hyperemesis Gravidarum care in emergency department? Answer is exact same as it is done in the ambulatory care. So I just discussed about ambulatory care. Same treatment will be in the emergency department. So that we can understand that in the ambulatory care and the emergency, there is no change in the treatment. Now, inpatient care, that is a hospital care. So again, the patient history would be taken, examination would be done, investigation would be done, diagnosis would be made, documentation like puke scoring is done, then admission is done. We already know what are the indication for admission. Now what is the treatment in inpatient care? So this is the summary: IV access, fluids, and with IV fluids, normal saline with potassium chloride, with the daily monitoring of electrolytes, thiamine supplementation, thiamine 50 milligram TDS or Pabrinex, vial of each intravenously. Venous thromboprophylaxis, protein pump, beta blocker or proton pump inhibitors, and like mental health assessment, appropriately referred to the perinatal mental health team, scheduling a scan to confirm multiple pregnancy, viable pregnancy or trophoblastic condition. If constipation, then gives consideration for giving laxatives. And at the end, when all things have failed, consideration for enteral or parenteral nutrition. So this is the all treatment that is given in the inpatient treatment. Okay, inpatient management. So this is important for both part 2 and part 3 people. And this part is again the same type of antiemetic therapy, discharge advice, titration of antiemetics, and postpartum care. Okay, so this is the summary tabulated in one paper about the about the this the treatment of the patient as inpatient. This is how, a complete summary as inpatient treatment of hyperemesis gravidarum that I have broken in the small sections. I have already explained it. This is a can come in for part 2 people, that orofacial cleft in non-exposed pregnancy would the it will be 11 per 10,000. But if the ondansetron has been given in the pregnancy, it could be 14 per 10,000. So there is a very small increase, like in 10,000 there would be 3 cases more if the ondansetron has been given in the pregnancy. So maybe part 2 people can get question from here. So that's all I had to say. So any one of you have any question can ask me. Otherwise, I would do some question. Any question, anyone? Any question, anyone? No question. Okay. So there are a few questions that I have put. So how this I have we have already done. How many times HG associated with low quality of time life?
3 to 6 times, ma'am.
3 to 6 times. Now, yeah, this would be important question. So, 33 year old patient, Gravida 3 Para 2, comes in emergency department for excessive vomiting last 3 days. She is asymptomatic, normal history, admitted with thyroid function test, low TSH and raised T4. What is the important feature that to differentiate between transient hyperthyroidism uh, of hyperemesis gravidarum from hyperthyroidism? So how you will differentiate? Yes, negative antibodies. So negative thyroid receptor antibodies. This I have already explained. These patients rarely will have thyroid antibodies, and they are euthyroid clinically, and the treatment would not be necessary. So this is the important message. Now, at what gestation the symptom will peak? Yes, 9 weeks. That we already know. So what is the appropriate solution for rehydration? Yes, normal saline with potassium chloride. Now, yes, so what defines the hyperemesis gravidarum in severe protected NVP? This is old criteria. New criteria has been changed. So answer is B, that is electrolyte imbalance, like 5% weight loss and ketone urea. But this criteria was previous. Now definition of hyperemesis is uh, nausea and vomiting in early pregnancy enough to cause inability to eat, drink, and limitation of the activities, and the signs of dehydration is there. Now, how many people will have abnormal thyroid test?
60%.
66%.
66.
Yes, yeah, 2 by 3. So what type of acid base abnormality is there? Metabolic alkalosis. Yes. Why? Because patient is vomiting, so acid is coming out. So if acid is coming out, there has to be alkalosis. So so like what could be there? Hyponatremia, kalemia, low serum urea, raised hematocrit, and also there could be ketonuria with metabolic hypercholoremic alkalosis. Now, what is the scale that is used for assessment?
puke,
Yes, puke score. But this Roddy's index of nausea, vomiting, and retching, this is also one of the scale, and but this is used for vomiting in the cancer patients. Okay, and this new guideline we have got another score also, that is
help,
the help
help,
score. Yes. Now, a 39-year-old woman admitted with gynecology hyperemesis gravidarum. She's 8 weeks, and this is her fifth admission with hyperemesis. Oral steroid didn't help. Nasogastric tube inserted for feeding. Intravenous IV line inserted for fluid replacement. Significant amount of weight loss is there. So, what is the recommended treatment? Change in tube, continuous steroid, hold MDT team meeting, seek advice from the specialist in early pregnancy assessment unit, do nothing, do none of the above. Yes, see, we have to hold a
meeting,
meeting. Yes, we have to hold meeting with a dietitian, nutritionist, pharmacist, endocrinologist, gastroenterologist, and psychiatrist to discuss the treatment. So, what is the most What is the most likely electrolyte derangement? All hypo, so it has to be
E,
E. All are
E,
less. Okay, in vomiting, all are less. So, how many portion of the pregnant women affected by nausea vomiting in pregnancy? Now it is 90%. Previous
90,
guideline it was 80. Now it
80,
has to be E, because it has now the answer is 90%. Okay, so how do you diagnose hyperemesis? It is again the old answer. So the answer would be like this electrolyte imbalance. Answer is E, but now the answer is now the definition of hyperemesis has changed. I'm putting this old question so that you have to understand what how they defined hyperemesis previously and how the hyperemesis gravidarum definitions change now. So this is the hyperemesis definition now. So that's all I had to say. So now there would be an offline course in Delhi. So for May exam, so all of you, like those who are interested, can contact after your exam booking. And all the best for your exam booking. Any one of you have got any question? Okay, people. All the best. Bye. Thanks for joining.
thank you, ma'am.